Hello, everyone. Thank you for joining us today. My name is Aline Sigler. I'm a specialist with Provider Outreach and Education at WPS. Assisting me today is Leanne Foster. I want to thank her for making sure things run smoothly. She's adding details to and monitoring the chat for me today, so I want to thank her so much for her help. Be sure that you visit the training center of our website. We start our webinars with these housekeeping items just to try to give you more information and some helpful details that going forward could assist you. So on the training center of our website, this is where we post the event materials for webinars. Do that about a week in advance, so about 5 days. So if you want to download a copy of the slide deck, you can find it on our live events page. This is also where you can find out about and register for upcoming educational events. Someone may have forwarded the link to this webinar to you, and so that's where you're going to find it in the future. You'll see a whole list with the descriptions and everything on that page. We did have a lot of people, thankfully, that signed up last minute. So if you've just signed up in the last few minutes and you haven't downloaded the presentation, you don't have to scramble and try to do that now. You don't need it to participate in the training, but just know that it will be removed from our website later today or early tomorrow. So maybe right after the webinar closes, if you think you want to have a copy of that, you can go out and grab it. Or the recording of this webinar, other live webinars that we do. Those are on our website as well. They're an encore presentation. So if you missed the event, you want to listen to an event again, that sort of thing. Depending on the number of events, we normally have those recordings available for 60 to 90 days. You can also find them on our YouTube channel. Use the chat feature to add any questions that you have related to today's topic. At the end of our prepared remarks, we will take as many questions as time allows. I will tell you that we received a lot of pre-submitted questions. That one question during registration that asks, what's one thing you want to take away from this training or something like that? And a lot of you did. And so I will go through those pre-submitted questions first. We'll see where we're at with time, and then we'll take as many live questions from the chat as we can. Whether you're listening live or you're listening to the encore of this webinar, we hope you'll take the opportunity to give us your feedback by taking a survey. Those surveys are so very important to us to let us know how we're doing and to give us insight into the type of education that you want and you need. This disclaimer is to inform you that we do our very best in providing accurate and up-to-date information, but Medicare is a federal program, and so sometimes it does change. So if there's ever a difference between what's in one of our presentations and what's on the CMS website or in those regulations, then of course those federal regulations are going to take priority over our education. Last thing I want to make you aware of on this slide is that CMS does prohibit the recording of our presentations for profit-making purposes. We're recording them for you, so there would be no need for you to do that or take screenshots. We're giving you a copy of the slide deck, that sort of thing. So just to notify you of those things. The purpose of this webinar is to discuss the correct billing for modifiers JW and JZ. We'll begin with a review of some general modifier information. We'll define what each of those modifiers mean, and then we'll move into what the regulations say about their use and the rationale behind the rules. And then we'll finish up, like we do a lot of times, with some resources on where you can go to get more information. The next two slides have acronyms, and these are acronyms that I used when I made the presentation or that I know I'm specifically going to mention. You know, Medicare has so many acronyms, too many to memorize, and sometimes they can get kind of wordy with limited amount of space on our slides. We use acronyms to just kind of make it easier for us. But we realize that some of them might not be as familiar to you, and so giving you these lists here will give you something to look back at and refer to. The more you use them, the more they'll become familiar to you. So we're going to start our presentation with defining some terms. And the first one is modifier. Modifiers are essential tools in the coding process. They're 2 characters, which could be letters, numbers, or a combination. They're added to a CPT or a HCPCS Level 2 code. When we use them, it provides additional information about the procedure, the service, or the supply that you're billing for, and it gives us a more accurate representation of what was done for the patient. They help clarify how things should be paid or processed by changing the description of the service in order to improve the accuracy or the specificity. If you're a biller or a coder, that word specificity is a big deal. You know, think of modifiers as a way to tell us the story of a particular encounter. Maybe a coder uses a modifier to indicate a service did not occur exactly as defined by the code descriptor, but that the situation didn't change the code that applies. A modifier can also give details not included in the code descriptor, such as the anatomic location of the procedure. We have modifiers that tell us right side, left side, which finger, which toe, those types of things. A modifier can also give details such as, in addition to the anatomic location of the procedure, the route of administration, things like that. Forgetting modifiers or using the wrong modifier can delay claims processing or cause denials. This can result in rework, payment delays, and loss of revenue. As you see here, some modifiers directly affect payment for the service, and we refer to them as pricing modifiers. Some are considered statistical modifiers and are informational only, but they're no less important in billing accurate claims to Medicare. We're going to touch more on this in the next couple slides, these differences. Pricing modifiers, what are they? They're also called payment impacting or reimbursement modifiers. They cause a direct change in pricing for the code that's reported in the multi-carrier system, or MCS. When more than one category is applicable for a procedure, you want to use the pricing modifier first. It takes precedence and it must be placed in the first modifier field to ensure proper payment. So there's kind of a hierarchy here. The other category is informational modifiers. Another name for them is statistical modifiers. Even though they're not pricing modifiers, they can also affect whether a code gets reimbursed. In this way, they're still relevant to payment despite being called informational. I'm using air quotes. There are 2 types of modifiers that we need to define as well. They are level 1 and level 2. Level 1, also known as CPT, current procedural terminology modifiers, are 2 numeric digits They're updated annually by the AMA, the American Medical Association. Now, for Medicare purposes, the explanation and application for some modifiers might vary from those of the AMA. So you want to keep that in mind when you're billing Medicare versus some other insurances. Level 2 modifiers are alphanumeric or have 2 letters within the range that you see listed here on the slide. The modifiers are national, but they might not be recognized by all payers. They're also updated annually, but this time by CMS, which is, of course, the Centers for Medicare and Medicaid Services. A couple more definitions. The official definition of modifier JW is drug amount discarded, not administered to any patient. What is this used for? To not only report the amount of a drug that was discarded, but also to obtain payment for the discarded amount that's not part of the dosage that's prescribed. The definition of JZ, it's used to report that no amount of a drug was discarded or not administered. Why would this be important? Well, number one, for reporting purposes, and number two, because CMS said so. So those are some definitions to kind of get us started in our discussion today. Now let's take a look at the policy that's outlined by CMS regarding these 2 modifiers and how it pertains to discarded drugs and biologicals. The rule applies to providers and suppliers that purchase and bill for separately payable drugs under Medicare Part B that are supplied in a single-dose vial, container, or package based on FDA-approved labeling. The rule actually applies to several different places of service, but it does not apply to rural health clinics. We had a question about that. Federally qualified health centers, or hospital inpatient admissions that are paid under the inpatient prospective payment system. As this slide here states, it's also not applicable to drugs packaged under the outpatient prospective payment system or ambulatory surgery center. Another exception to make note of is that the JW and JZ modifiers are not required for certain vaccines like influenza, pneumococcal, and COVID-19. Why is that? A lot of times they're furnished from single-dose containers, but since those vaccines are often roster billed and roster billing cannot accommodate modifiers, it wouldn't be practical to require them. We did have a pre-submitted question asking if all vaccines are exempt, and the answer is no. CMS only specifically stated the ones I mentioned. Now, this policy for discarded drugs and biologicals is not a new policy, but it has evolved a bit since it began with modifier JW on January 1st, 2017. After being in place several years, CMS found that the JW wasn't being used very much. So they also created modifier JZ for when there is no discarded drug amount. Some of you asked, what is the rationale for this policy and why are we doing this? The 2023 Medicare Physician Fee Schedule Final Rule talks about why we need the information provided when using the modifiers. In part, it allows CMS to work with the drug manufacturers on rebates. That might also be the answer to why is CMS separating out certain manufacturers with their own HCPCS code. So those are some of the pre-submitted questions that we got, and I wanted to insert them here because it makes sense when we're talking about the policy, the background of it, and the rationale for it. So thanks for sending those questions in. Now let's look at billing for the modifiers. For facilities and institutions that send claims on the CMS 1450, UB04, or the 837I electronic transmission, this slide here shows the form locator or segment that the modifiers will be populated in. So on the UB04, it's form locator 44, and that's labeled as HICS, HIPS, or rates. And HIPS is HIPPS, Health Insurance Prospective Payment System. That's just the name of that field or that column on the UB04 form. If you're billing electronically, which the majority of our providers do, you'll see the segments listed here where you can also find where that information goes. So likewise then, if we flip that over, if you work with physicians and non-physician practitioners, those professional charges are billed to Medicare using the CMS 1500 claim form, or the electronic equivalent of that is the 837P. And that's form locator 24D, and it's labeled as procedures, services, or supplies. I do need to make a clarification here on this slide. When talking about the segments, the SV 101-2 is the spot for the procedure code, and then 3 through 6 are the modifier spaces. So that's where it goes. So now if we want to move on, we want to look at, because I know a lot of you, the questions that we got are related to billing. So let's look at some audits, appeals, and corrections. Talk about those a little bit. So starting with reviews for the JW or the JZ. I mentioned that the policy had evolved since its inception in 2017. And that's when it started with the JW requirement. And then this slide outlines some of those changes that have taken place. The voluntary use of modifier JZ went into effect on January 1st, 2023. I mentioned the final rule a little bit ago, and that was the 2023 one. But then starting July 1st of 2023, it became required. So started being accepted on claims on January 1st. It was voluntary, but then became mandatory July 1st of 2023. And since then, claims for drugs from single-dose containers that do not include the modifier JW or JZ might be subject to audit. So we might halt the claim, ask for records, compare it with what was billed, that sort of thing. Now, claims with dates of service on or after October 1st, 2023 that don't report the modifiers will or might be rejected. So it became voluntary, then the codes became mandatory if the situation justified it. Then we started doing audits, and then CMS made a line in the sand that said, okay, if you don't do it as of this day, then we're going to reject or deny them. The edits that we're talking about, or the audits or the reviews, those can be automated, meaning the system reviews them for accuracy, or they can be a complex review, meaning that they're actually looked at by a person. The reviews can be done by WPS as your claims processing MAC, or by another contractor that's working for CMS. So we're trying to make sure that you know about the rules so that you can avoid rejected or denied claims. A reminder here about documentation. Make sure to clearly document the actual dose administered, the exact amount wasted, and the total amount the vial is labeled to contain. That kind of detailed documentation benefits you by justifying your billing in the event that an audit should occur. So if you get into the habit of documenting all that information, you have it. We did have a question submitted about documentation, so I hope that helps you. If you're asked to submit documentation to support your billing, make sure you submit it timely. A lot of times there is a deadline, a date that that documentation needs to be received by, or it will automatically be rejected, and you don't want that to happen. So trying to spread the word, trying to get the information out there to know that this is important because there are dollars at risk for you and your facility or your office if it doesn't happen. Now, if you downloaded a copy of the presentation, you'll notice a typo on this slide, and I apologize for misspelling unprocessable. That's 100% my fault, and neither spell check nor the peer review caught it, so I apologize for that. If you have a claim with charges that are non-covered, the reason that they're non-covered is what's going to determine your next steps. So what you need to do is investigate to determine if the line was unprocessable. A claim is considered unprocessable when it contains incomplete, missing, or invalid information, and it actually prevents Medicare from adjudicating it. This is a Part B term, so if you're a Part A provider, it might not be as familiar to you. Your claim might be rejected. A rejected claim is usually unpaid due to a billing or a technical issue. Your remittance advice will give details on what the message about your claim or line means. In many instances, you can rebill a corrected claim. So if you left the JW or JZ off completely, you could resubmit if the situation justified it, a corrected claim. Another action that you might take in some situations is an appeal. You're going to be looking for remittance advice remark code MA01. That tells you that the service has appeal rights. If the service was denied and you disagree with the initial determination, you can submit a redetermination request within 120 days. If you do, be sure to include a correctly completed paper claim form. And I say that because our appeals area has communicated to us in provider outreach and education that they receive a lot, and that's in capital letters, a lot of requests that are not complete or not correct, including the items that you see here. We have codes for drugs that come in a single-use package, and the claim does not contain a JW or a JZ. Also, a lot of instances where there's no paper claim form with the appeal request, or no medical records were received when necessary or requested. So again, trying to make you aware of these situations. Maybe you haven't been in this situation yet. If it presents itself, we want you to take that information and be proactive. So that's why we're trying to share this. So I hope that's given you a better understanding of modifiers JW, JZ, and their use, when they should be used, when they have to be used, and that sort of thing. Now this slide here contains resources that are published by CMS for more details. And I've mentioned a couple of these before, so I'm just going to kind of go down the list here. If you downloaded a copy of the slide deck, you have these links. If you're listening to the encore presentation, scroll down to the description of the video and you'll find the links there. Now the first one is the Medicare Learning Network Matters article 13056. I'm going to navigate to that. It'll take just a second to open up. Just got to make sure it's a safe link and that sort of thing. So this is published by CMS. The Medicare Learning Network is the CMS education hub, if you will. And this actual article talks about the JZ, but it also gives a good background about the policy itself and how it got started, because I know a couple of you asked about the rationale, and I'm trying to scroll slowly. But you can also see other information here. So I wanted to bring that to your attention. Another item that's on your resources slide, and there's a link to it here, so I'm going to use this as a jumping off point, and that is the JW/JZ Frequently Asked Questions document that CMS has put together. So this is a good resource for you here, because these questions are a lot of the questions that I actually received during the registration. And so this is a good resource for you. You'll find all kinds of information in here for different provider types. And so I wanted to make sure that you knew that that existed. And then the other resource I have for you is actually linked here too, and this is Chapter 17, Section 40 of the Medicare Claims Processing Manual. So I'm going to use this link here. And again, that's Section 40. This is where you can actually read the regulations about the discarded drugs and biologicals. It contains billing examples, which is also good, and things like that. Let's jump back to our slideshow now and go to the next slide. And here's a few more resources that you might find beneficial, and these are on the WPS website. So the first one is an article about modifiers. Now, if this is the first time that you have stopped by the WPS website today, you're going to choose a jurisdiction. I'm just going to choose J5 Part B for our example here, accept the agreement. You can absolutely use the search feature to find this, but I want to show you how to navigate it as well. So if we start with the Topic Center, use that drop down, and we're going to go to Claims. Then I'm going to scroll down, and I'm sorry, I have to scroll down a little bit because it's alphabetical, and we have a heading for modifier. You see it listed here. If I expand that, there's the link to get to that article that I was just showing you. So this is a good resource, and it also gives you a good jumping off place to other items. I do want to show you that this page has a lot of additional modifiers. So they have different groupings based on what the modifiers are relevant to. And you can see right here under drug modifiers, we have a fact sheet for modifier JW and JZ. They're similar. I'm just going to click on one so you can get a look at it. What it's appropriate for, when it's effective, some billing examples, and places where you can go to get more information. So that might come in handy as you continue learning about Medicare, learning about modifiers, not just with the JW and the JZ, but in general. So now let's go back to the top of the page here. and go back to our modifiers page. The other article I want to show you is Introduction to Modifiers. This page gives you those definitions that we went over just a little bit ago about level 1, level 2, pricing versus informational, and so on. So just wanted to show you where you can go to get more information, because that's really what Medicare is all about. Not being or not having to memorize everything, but knowing where to go to find the information that you need. So now it's time for questions. And as I stated, I did receive several during the registration process, and I've already addressed a few of them. But multiple people asked which medications, which J codes require a JZ or JW modifier. How do we know when JZ or JW modifiers are needed and when they are not? And are there certain medication HCPCS that automatically require the JZ or JW modifier? So those are great questions, and they're related, so that's why I kind of combined them. So the first recommendation, your first determination is whether the drug or biological is separately payable, and if it's a single-use package, vial, or container. If it's not, then the JW and JZ do not apply. How do you determine if it's a single-use package? Well, you're going to use the package insert from the drug manufacturer as the determining factor. All single-use package claims should contain a modifier JW or JZ, but usually not both. And I say usually because sometimes multiple lines are required due to the number of units. You're probably all familiar with some of those drugs where the number of units that you bill on the claim is very high, and sometimes you have to bill that on multiple lines. And if you use a JW, the system is programmed to also look for that same code without a modifier to tie it together. There is a list of billing and payment codes that may require the JW and JZ modifiers. It's not an all-inclusive list. It is updated semi-annually. I didn't get the link on your resources slide. I apologize for that, but I will have Leanne add it to the chat there. You can link to it from some of the other documents that we briefly looked at there. So I hope that helps you. So it's not a one-stop shop. That spreadsheet is very good, but CMS does tell us that just because a code is not on that list doesn't mean that it doesn't apply to the policy or vice versa. Next question. This was actually sent in a few times also. How do I determine the amount discarded? So generally, the discarded amount is the labeled amount on the single dose container or containers, if more than one is required, minus the dose, and the dose is that's being prescribed for the amount of the drug administered to the patient. So sorry. In determining any amounts discarded, refer to that package insert. It's going to list the number of units, whether it's milligrams, milliliters, etc., that's included. Then you're going to look at the procedure code description, and I would look at the long descriptor to determine what it is as a unit of service. Determine the amount given based on the units identified by the procedure code and the single dose vial. So you're going to want to verify the milligrams or whatever administered to the patient and then convert them to the proper units for billing. To determine the discarded amount, subtract the dosage administered from the labeled amount of the drug container. Next question. Are these modifiers insurance specific? They are primarily associated with Medicare Part B, but that's not to say that they couldn't be adopted by other payers if they chose to. So check with the payer in question. Many follow the Medicare guidelines, especially for drugs administered under Part B. Next question. When adding the JZ, JW, are we also required to add the JA, JB modifiers? If you're not familiar, JA means intravenous and JB means subcutaneous. And the answer to that is that this discarded drug policy does not change any other billing criteria. So if those would be required in your instance, yes, you would still want to include those. Next question. What are the injection rules when done in an RHC? CMS does state in this policy that it does not pertain to drugs administered in the RHC or FQHC setting. Next question. What are the critical access hospital or CAH JW/JZ requirements if different than non-CAH facilities? The JW and JZ modifier requirements also apply to critical access hospitals since drugs are separately payable in the CAH setting. And that frequently asked question document that I showed you just a little bit ago, question 6 actually states that. So this policy does apply to critical access hospitals. Next question, is this only for injectables, meaning a push, or is it for intramuscular and subcutaneous as well? What about infusions? The policy is not route specific. It is based on the code, whether or not that code is separately payable and a single-use package. The list on the CMS website has injections, but as I was scrolling through, I also noticed some implants, patches, suspensions, etc. Next question. For single-dose packaged drugs with status indicator N, should wasted quantities be included in the charge line with the quantity that was administered, or should the wasted quantity be omitted from the claim? Well, the policy does not apply to packaged drugs with a status indicator of N. CMS does make that clear. This is for separately payable drugs. Next question. We are assuming the drugs with CMS's new K1 status indicator will also need the JW/JZ modifiers. My advice to you is to check that spreadsheet. Ask yourself if it's separately payable and in a single-use container. If so, it probably will require the modifiers. Next question. How can I tell if there are any claims being billed by my facility with the incorrect or missing JW/JZ modifiers? Is there a unique remittance advice code or line adjustment code? My charge services department tells me that I cannot simply review cases for drugs that are on the single-dose vial list because most of these drugs come in both a single vial and multiple vial formulation. This question is a tough one, and it may be unique for each of you. It might be a combination of comparing the list of single-dose vial drugs and looking at your remittance advice. Some that might indicate that there's an issue, some of the codes or the remarks would be CO4, missing medical modifier. This denial code indicates that a required modifier is missing from the claim. If the JW or JZ modifier is applicable but not reported, The claim may be denied with this code. Excuse me. Another one, CO16, incorrect or missing information. Now this code signifies that the claim lacks necessary information or contains an incorrect modifier. Incorrect use of the JW or JZ modifier could lead to this denial. So it's not one thing or the other. Just looking at the list of drugs isn't going to give you all the information you need, nor is looking at your remittance advice. It's going to be a combination of the two, and then it's going to be a matter of figuring out what works best for your office or your facility to know whether or not you have claims that are not in compliance with this. But I commend you for wanting to be proactive and wanting to know if that's an issue, because that could be a teachable situation for your office. So thank you for that question. Next question. Why is my claim denied when I used 2 vials and only one has wastage? An example that I can give you here is if you use 2 single-use vials with 50 units of service, and let's say you administer 75, you're not going to bill one line with 50 and a JZ and one line with 25 and a JW, and you're going to combine those 2 vials, and you're going to bill one line with 75 units with no modifier, and then a second line with 25 units and a JW. I hope that makes sense. I kind of got a little tongue-tied there. Next question. There's no assigned J code, but we gave 9.5 and waste was 0.05. How do we report when the system does not allow for half units? Well, you're right. CMS does not use fractional billing units. It's going to depend on the billing unit. So check the package insert. Without myself knowing the drug in this situation, my guess is maybe one unit is 10. You're probably going to report administering the full billing unit along with the JZ modifier, since the JW modifier wouldn't be used if the dose of the drug administered is less than the billing unit. I didn't really have enough information there to know the full situation, but I hope that did help. Next question. Q5106, is JW or just JZ the most appropriate? I really can't answer this. The drug is not on the spreadsheet. I did check that, but it's not an all-inclusive list, as CMS has said. So you're also going to have to check if the drug is separately payable, a single-use vial, and was there a discarded amount or not. That's what's going to help you work through that. Next question. What do I do in this scenario where there are too many modifiers and the claim is denied? The provider indicated that they were ophthalmology, so I'm assuming that they're billing on a 1500 claim form. It allows for the entry of up to 4 modifiers for each procedure code. If you need to include more than 4 modifiers for a particular service, you should use modifier 99, which means miscellaneous modifier, as your 4th modifier, and then list the additional modifier or modifiers and any relevant supporting information in item 19, which is also known as the additional claim information field on the 1500 claim form, or you can use the narrative field of an electronic claim. Next question. What if you receive the patient's dose from a pharmacy and the exact amount to be administered? Oh, excuse me, with the exact amount to be administered. So there is no waste, but the NDC number associated comes in a larger vial. Since you do not have waste, is only the JZ modifier appropriate? Well, if the drug is not a single-use vial based on the FDA-approved labeling, the JW and JZ wouldn't apply. The use of these modifiers is not appropriate for drugs that are from multiple dose containers. Next question. What is the proper way to submit a physician claim with multiple NDC numbers for the same drug code? If there's discarded drug, what you're going to do is identify the HCPCS code and the NDC for the administered drug. Typically, again, as we stated, it's found on the drug vial label. You're going to determine the billing unit based on the HCPCS code's long descriptor. Document the administered and discarded amount within the patient's medical record. You're going to create two claim lines, one for the administered amount without a modifier, and one line for the discarded amount with the JW modifier. And then you're going to repeat that process for each unique NDC and vial with discarded drugs. You're going to make sure that your documentation clearly shows the administered and discarded amounts for each. And if you still have trouble, contact our customer service area and they can help you getting that claim processed or give you advice and look at the claims with you in the system and see what the issue might be if it gets hung up. Next question, what is the proper way to bill the JZ when drug was given but out of two separate vials? One vial is a single dose vial and the other is multi-dose. Well, when you're billing for a drug administered from both a single-use vial and a multi-use vial, the JZ modifier would only be appended to the claim line for the single-dose vial if no amount was discarded. The multi-use vial does not require either the JW or the JZ because it's not subject to these discarded drug rules or policy, if you want to call it a policy. And then finally, the last pre-submitted question, what are the rules regarding status indicator N1 when the JW is billed? The JW and JZ modifiers don't apply to drugs that are assigned status indicator N or payment indicator N1, and you can find that answer in those frequently asked questions. So now I want to check in with Leanne. We have just a couple minutes to see what questions you have related to today's topic. If it's anything too claim specific, I might have to refer you to customer service. But we also will give you an opportunity to get your questions answered if we run out of time. So Leanne, what have you got for me?
We do have quite a few questions, and I don't know if we'll get to all of them, but we'll go ahead and get started. The first question is asking how quickly do commercial and Medicare Advantage plans align with CMS on use of modifiers JW and JZ?
That is a good question. However, I can't answer it. Since they are completely separate entities, they are, doing business at their own discretion and on their own timeline. So I'm afraid I can't help with that. I'm sorry.
All right, next question. Are you aware of any issues with MUEs for drugs with a single dose vial? We have been seeing issues with CPT code Q5106. This is a single dose vial with 40 units. We often administer 60 units, which necessitates us billing for 20 units of wastage. There is an MUE for this CPT of 60, so we're seeing denials for exceeding the MUE when we bill for 60 covered units and 20 wastage units.
Okay. I haven't heard anything specifically, but that doesn't mean that it's not a known issue and I just haven't become aware of it. My advice to you, if you have claims like this, contact customer service so that they can look at them with you. The Q5106 was mentioned in the pre-submitted questions, and although it's not on the spreadsheet, we know that that's not an all-inclusive list. So if the policy does pertain to it, and we kind of have two different balls bouncing back and forth here with the MUEs added in, but I would contact customer service, have them look at it with you. It might be a case where it processes and then you have to appeal it maybe and send in documentation to get it to process until the system can be updated if that's what needs to happen. Thank you for that question.
The next question is in reference to that list that we sent out. And everybody, I did send out an updated URL. It did look like there was a hyphen that has maybe changed position, so that was sent out. So if you had trouble accessing that list earlier, you do have the correct link in the chat now. So the question is indicating there are codes on that list that are packaged with status indicator N. Why is that when only separately payable drugs are supposed to be subject to waste modifier reporting?
That's a good question. It might be that something has changed. That list is, from the information that I could find, updated semi-annually, and so something might have happened in between updates. So other than that, I'm not sure. That's the list that CMS has directed us to use, but also clarified that it's not an all-inclusive list. So I guess I don't know.
Next question. We're having issues when billing Medicare for a drug that has multiple NCD codes, therefore billed on 2 lines. Both drugs are SDV and both lines have JZ modifier appended. Medicare will deny 1 line for B13, previously paid. So how does WPS handle it when this is billed so we don't continue to get denials?
Yeah, that's a good question. I know when there are multiple NDCs for the drugs that the system, has a hard time knowing which one is associated with line. And I know that if you have wastage and some that does not have wastage for the same drug, but with different NDC codes, it all has to be spelled out on the claim. And so when you have troubles like that, I would contact customer service. There might be something in the works where that's an issue that's been referred, or there's an edit or an audit maybe in the system that needs to be tweaked a little bit by our systems department, but they could advise you on that and see what we can do to hopefully prevent that from happening if you are following the guidelines and doing what you're supposed to do, but the system isn't recognizing that. So unfortunately, I hope that can get cleared up for you.
And Aline, we just have 3 more questions in the chat, so we're getting through these well. So the next one is, are drugs with a status indicator of N1 included in the JZ JW modifier requirements if billed not in an ASC setting, or is this only applicable if billed in an ASC setting?
The payment indicator N1 is not included in the JW and JZ policy. And I did find that in the frequently asked questions document. So that's considered a packaged drug. And the policy, again, is only for those separately payable drugs. So the N and the N1 would not be included.
Okay, next question is, I'm assuming that a claim can have both a JZ and a JW. 1 full vial was given on one day and then a 25 milligram dose the next. Would you have to list both a JW and a JZ?
It's possible, yes. But just remember that for that drug, if you're using the JW, the system's going to be looking for a line that does not have the JW to say, okay, here's how much was administered and how much was discarded. And so if there are multiple dates of service, the system's going to be looking for those and how they correlate. So it would be possible to have both.
And Aline, this is the last question that we have in the chat. The question is, are JW and JZ applicable to medications with status indicator K1?
Yes, they could be. If they are separately payable, and that's what that indicates, and they're a single dose vial, then yes, they could pertain to that. Thank you all so much for those questions. I think that they are great to know that those questions that you have, probably someone else has that same question or a similar question. So I think it's really helpful for all of us. We're going to move on now and finish out our time together today. I want to share an announcement with you just to make you aware. Ask that you pass this information on at your facility or in your office. And it's a process change that's coming very soon for our customer service area. To better serve our providers and streamline call handling, our contact center is going to accept one NPI and P10 combination per phone call effective August 4th of 2025. And this change is being made to improve call efficiency, decrease call wait times, and ensure quicker resolution of your inquiries. So just a quick announcement there. Now, within a few minutes, in the next 5 or 10 minutes, you're going to receive an email that's going to thank you for attending. And I want to make you aware of it because if you haven't attended our education before, you may not realize that this email also contains your certificate of achievement. It's going to look similar to what you see on the left side of the screen here. It has your name, your contact hours. So if you need to turn it in for credit toward continuing education units, you can do that. If you don't see it, check your junk or your spam folder and make sure that the WebEx email address is added to your safe sender list. For those of you who are listening to this as an encore, we certainly thank you for taking the time to learn more about this policy, but we don't have a way to verify your attendance, and so a certificate of achievement is not possible in that instance. Just wanted to be full disclosure there and let you know about that. Now, if you think of a question later, you do have 1 week from today to submit a follow-up question. Send them to our same email box that we have listed here, our education mailbox, we call it, and put today's date and something about the JW and JZ modifiers so that the person who is looking at that mailbox and sorting through things, they will forward those directly to me. Please take a few minutes, like I asked earlier, to complete a survey about this course. Tell us what you liked. Tell us what we could do better. Give us suggestions for future education. We take your feedback very seriously, and it is shared in real time with CMS. You have a few options depending on what your preference is. You can use the link that I asked Leanne to put in the chat, or when you exit the webinar, you're going to be asked to go to an external site. And an external site is the CMS Qualtrics page for the survey. And that message is going to look similar to the screenshot here with the triangle and the blue continue button. You'll just click on that continue button. It'll take you right to the survey. Also in that thank you for attending email, you'll see that there is a box that also has a link for the survey. You only have to take it once. It just depends on how you want to get there. And I recommend doing it when it's fresh in your mind too. That's helpful. If you're listening to this as an encore, we also have an opportunity for you to take the survey. A box is going to appear that's going to take you to that survey, and it's going to look like the other example here with the finger and the stars, or you can scroll down to the description for the video and find the link there. However you choose to do that, let us know. Let us know if you'd recommend our education to others. How likely are you to attend other events that we host? Those surveys give us insights into how we're doing and the types of education that you want and need. just to let you know that we do look at those surveys and we do take your feedback to heart, and that we are committed to making changes to improve your education. I have a couple examples here. Based on survey comments, we have incorporated chapters into our YouTube videos. So now you can jump to specific sections within a video. We're also beginning to use what we're calling training indicators to help you determine if an event or material applies to you. You'll see them in the description of the course. So it might tell you that the training is a certain benefit category, whether it's clinical or billing in nature, if it's part of a series, that type of thing. And we do have a page on our website that defines what all those training indicators mean if you want to learn more about that. On behalf of myself, Leanne, all of us in Provider Outreach and Education, I want to thank you for your time and your participation. We hope to have you join us for future education, and we look forward to your survey feedback. You may now disconnect.